Hi, my name is Lucy Alvarez. I'm interested in becoming a registered respiratory therapist. Today I've been given permission to job shadow a lead registered respiratory therapist at Summit Medical Center. I'm so excited.
Good morning, Lucy. I'm Lindsay Maybray, and I will be mentoring you today. I have just received orders from our pulmonologist to evaluate a patient for potential discharge. Since you've completed HIPAA and have satisfied your requirements for the Human Resource Department, you have been approved to examine the patient's medical information with me. So let's review the patient's, begin with reviewing the patient's electronic medical record. I always like to begin by reviewing admission information. It contains SOAP and gives me a lot of information about the patient. The letters of SOAP represent S for subjective, that's how the patient feels. O for objective, that's what is physical and what you see. A is for assessment, and that's just how you assess the patient. And then P is for plan, and that's how we plan on treating the patient. This patient is well known to our department. Her name is Mrs. Tubbs. She's a 54-year-old African-American female. She was admitted about a week ago for COPD exacerbations. Okay, let's look at here's our electronic medical record. S, subjective. She says, I feel like I'm smothering and can't breathe. O, objective. Her heart rate is 138 beats per minute. Her respiratory rate is 28 breaths per minute. And her blood pressure is 148/98. Her temperature is 100.8 degrees Fahrenheit. Accessory muscle uses hyperresonant percussion notes and diminished breath sounds with end expiratory wheezes. Her general appearance, she's cachetic, increased AP diameter, no digital clubbing, no pedal edema. Her chest x-ray shows bilateral lower lung infiltrates, hyperresonant and flattened hemidiaphragms. Her PFTs have decreased. The FEV1 to the FEVC ratio is 55% predicted, decreased, and the FEV1 is 35% predicted. Her room air ABG was a pH of 7.26, a PaCO2 of 78, a bicarb of 39, and a PaO2 of 41. Now we'll move on to the assessment part. She has bronchospasm, pulmonary hyperinflation, acute ventilatory failure on top of chronic ventilatory failure with a moderate amount of hypoxemia. Now we're going to go to the P, which is the plan. We're going to begin protocols for ventilatory management, oxygen therapy, and aerosol therapy. We're going to initiate non-invasive positive pressure ventilation with an IPAP of 10 centimeters of water and an EPAP of 5 centimeters of water. 24% FiO2. We're going to titrate the FiO2 to maintain an SpO2 of 85% to 88%. We're going to give her a stat 0.5 ml albuterol and 3 mLs of normal saline and obtain a sputum sample. Mrs. Tubbs appeared to be in a moderate amount of distress when she arrived. Look at her vital signs after she has been on BiPAP for 30 minutes. I'll explain non-invasive positive pressure ventilation to you later. Here are some PFT results from a clinical visit she had earlier this month. On this side is what was measured, and that's going to be her FVC, her FEV1, and her FVC to FEV1 to her FVC percent. This is her predicted. This is her pre-bronchodilator and her post-bronchodilator. Her FVC in liters for predicted was 2.4. Her pre-bronchodilator was 2.8, and her post-bronchodilator was 2.76. The FEV1 predicted was 1.92. Her pre-bronchodilator was 1.6, and her post-bronchodilator was 0.64. Her FEV1 to her FVC percent, her predicted was 82%. Pre-bronchodilator was 57%, and her post-bronchodilator was 59%.